The 10th season of Consider This is brought to you in part by From the Top, a national program showcasing the musical talents of young people. From the Top can be heard on KVNO Classical 90.7 each Saturday at 6 p.m.
Consider This, a program of issues and information behind today's news. Once again, from the campus of the University of Nebraska at Omaha, here is your host, Andrea McMaster.
Meth use in Nebraska is growing rapidly. Hello, I'm Andrea McMaster, and thank you for joining us for this edition of Consider This. There are an estimated 20,000 people in Nebraska with a meth problem. It's costing Nebraskans millions of dollars in child neglect and abuse cases. It's also putting an added strain on emergency and healthcare systems. In some of the areas of our state, rural areas are seeing even a greater problem, and that is the focus of today's Consider This. Dr. Kathleen Grant, who works with the Omaha VA Medical Center and the University of Nebraska Medical Center, is our first guest I want to introduce you to. She will talk about a new study that raises some disturbing questions on the use of methamphetamine, especially in the rural areas of our state. Thanks for being here. Glad that you could be here.
Thanks, Andrea.
And also Dr. Tina Scott, who is a pediatrician practicing in Plattsmouth, Nebraska with the Nebraska Medical Center. And she sees patients in the Plattsmouth Clinic, as I mentioned, and can also talk about really the effect of meth on our children. So we're anxious to delve into this topic. I know that the study that you conducted, Dr. Grant, has received already some national coverage and some national response, which has to be encouraging. I wanted you to go through a little bit of the background of why you thought this was necessary to delve into this topic in the first place.
Well, it's interesting, Andrea. We did not set out to study rural methamphetamine use. We were given a grant to look at tobacco use in methamphetamine addicts, and this was funded by the state of Nebraska very generously through their LB 506 funding mechanism. And during the course of the study, though, we began doing what we would call sub-analysis, looking at various populations that had enrolled in this tobacco meth study. And through the course of this sub-analysis, we looked at, among other things, at rural and urban distinctions. And I was amazed to see how little research had actually been done on rural methamphetamine use. I think many of us are aware of the national coverage that methamphetamine use has received in things like Time and Newsweek magazines, but there's really very little research literature on rural methamphetamine use. And when I first did the literature review, there was probably 2 articles in all of medical literature on rural methamphetamine use. So, and since then I think 2 additional articles have been published, but really very little is known about rural methamphetamine use and the characteristics of rural methamphetamine users. So in the course of this sub-analysis, we looked at various items that we thought would be important when attempting to characterize rural methamphetamine users. And these were all adults that were enrolled in substance abuse treatment. The study was done at 5 sites, 3 in Omaha, Catholic Charities Campus for Hope, Journeys, and the Omaha VA Medical Center, 1 site in Lincoln, Bryan LGH, the Independence Center, and then 1 site in Grand Island at St. Francis Medical Center. So all of our participants were actually in substance abuse treatment, and essentially we asked them to sit down with us and go through an information gathering questionnaire over about an hour and a half. And we asked various questions about age of first use, how much they used, how frequently they used, how they were using by intravenous means or other methods, and then also a lot about their psychiatric symptoms, things about depression, psychosis. And as our analysis progressed, we were astonished to learn, and I truly mean that, by the depth of the problem in rural Nebraska and the severity of the problem in rural Nebraska. We found during the course of our study that actually rural methamphetamine users are beginning their use about 3.5 years earlier than urban methamphetamine users. They're more likely to have alcoholism, which is very significant in terms of treatment outcome. They smoke more cigarettes, which certainly lends them to more medical complications related to their substance use disorders. And I think very counterintuitively, they're more likely to use intravenously and more likely to have psychotic symptoms. And when we use the term psychotic symptoms, we're talking about things like paranoia, hallucinations, delusions, symptoms that are very difficult for the typical family practice physician or primary care physician to even treat.
And when you talk about injection drug use, I just want to point out here that that's really risky. We're talking about even a greater risk than for like hepatitis C and HIV infection.
Correct. And that's very concerning because, again, most people with hepatitis C, which is very easily transmitted intravenously, most people with HIV are going to need specialty care for those infections. So if there's an increased frequency of intravenous use in rural settings, we're also going to see then increased HIV or AIDS infections, more hepatitis C infections, and typically when those are diagnosed, they're going to need specialty care, at least for a significant portion of their care rather than primary care. And I think the reason that's important is because, as Tina probably knows better than we do, rural settings, especially the remote rural settings, we find that patients have a much more difficult time getting psychiatric care, getting some of the subspecialty care than we would find here in urban settings.
Okay. Well, I want you also to point out, first I'm going to say that this study was published in the April edition of the American Journal on Addictions, right?
Correct.
Point out a little bit about why you think this is such a rural problem. You saw that it is. Why is it? Is it because no one's going to notice me? I'm out in the middle of nowhere surrounded by cornfields, or what's the mentality?
That's a very good question, and I'm not sure I have the answer to that. We know, for example, that rural 8th graders are more likely to use illicit drugs than urban 8th graders. That's just illicit drugs in general. So it's possible that in the course of this early use of substances, probably most of us would imagine that that would be alcohol and then marijuana, that they're introduced to methamphetamine. If they're using other drugs more so than urban folks, it's possible that rural 8th graders are just more likely to try drugs in general. It may be an access issue. As I'm sure you're aware, the publicity around rural meth labs has been significant, and it's possible that rural young people have just closer access or easier access to methamphetamine use because of local production. Although I might point out that really only 10% of methamphetamine has been produced locally in Nebraska. Most of it has been transported from
Mexico,
from California and the super labs along the West Coast. So that may or may not explain it. Another possibility, and again I'm just posing these as options, we know that many of our young people in small towns and small communities have very limited access to mental health care. It's possible that young people who have mental illness that's gone untreated are more likely to use substances, and perhaps they're accessing methamphetamine. But the bottom line is, I don't think we know yet why there's greater rural use, and I certainly don't think we know why it's earlier use in rural methamphetamine users than urban.
And would probably be helpful to really distinguish that in order to come up with some solutions and
Correct.
For the problem. But one thing that did come out in your study is that the rural environment really has a lack of recovery support. Meth addicts say that just really leads to an obstacle for getting clean, just that there's not really easy access maybe to some of that recovery support.
That's right. So we may be seeing people who have much severe methamphetamine problems in rural and in urban areas, but they have less access to treatment, at least easy access to treatment in rural settings.
Okay. Well, Dr. Tina Scott, I'm going to throw you in here again and introduce you. I just wanted to say that Plattsmouth is an area, probably not something that you're excited about, but I know that Time magazine published that Plattsmouth had the most meth labs per capita of any city in the U.S. And in the year 2000, Plattsmouth had a population of 7,500 people, but police seized more than 50 meth labs. So you're right there in the heart of the problem in dealing with these families and providing care to these families. So how often and what types of problems do you see in your office?
Well, I've kind of thought about that a little bit over the last couple of days. How often do we see it? We see it on a daily basis. If it's not a family of a meth addict, it's a family of a law enforcement officer who has to deal with the meth addict, or the kids that do find. We've had kids come in that have found these rural meth labs that just get pitched to the side of the road. Of course, parents are panicking and they want them checked out. So it affects daily we see it, these kids. It affects more than just the people that are using, more than just the people that are using in their homes, more than just the people that are making it. I think it's affected our entire community. We deal with it. I'm a part of a Cass County child advocacy team, and we discuss it every month it comes up. There are very few situations where children are removed from homes where methamphetamine's not brought into the picture.
And
on some level.
And it has to be disheartening to you, because some of the issues that come up with especially children of meth addicts or children who are in homes where there's meth labs, and how that affects children. And so I want you to kind of share just really how does this affect children from the dangers of being a child?
Yeah, and that's a very broad topic. One of the problems with methamphetamine is you get hypersexuality with it. So these folks are having lots of sex, they're having lots of children, and they're pregnant a lot. They don't stop their use when they're pregnant necessarily, although if we can catch them when they're pregnant and encourage them to stop, you have a better chance at it. But they're not seeking prenatal care. So these babies from the very beginning, from conception, have just a lot of increased risks. Methamphetamines, and again, not a lot of studies, but the studies that are out there are kind of conflicting in what kind of birth defects we see in children exposed to methamphetamine, babies that are exposed. And some studies will say nothing, and some studies will say, some cardiac defects. But along with the meth use comes alcohol use, other drug use, poor nutrition, poor prenatal care. So from birth, these kids are fighting a battle that is just going to be tough for them. And then once they're born, they're not pleasant babies. They're unhappy, they're fussy, they're irritable, they're difficult to feed. That increases risks for SIDS. It increases risk for shaken baby. Then they grow up in homes that are typically, if there's meth labs involved or even heavy users, they're set up for neglect based on the situation. I have a counterpart who at one point in time called it a drug that people will leave their lives for. They leave their jobs, they leave their families, they leave their children for this drug. And that's what they do. And so these children are growing up in homes where there may not be food, and the mom's not going out looking for food for her children. So we sometimes don't even see these kids until they're taken from these homes and brought in by Health and Human Services or by their foster families. When we do see them or we have suspicion of it, we of course try to intervene, sometimes trickier than you wish it would be, so it's difficult. And then you get these kids that may do well, but eventually at some point in time they're exposed to it. We have families where parents have introduced it to their children. For whatever reason, I can't imagine, but then you have a young addict as well. This is something that follows them throughout their lives. Even once they're removed from their homes, now they're in the foster system, and that's going to affect them. Attachment disorders and depression, anxiety, all the things that go with that.
And even if the parents aren't meth users, if the children are exposed at all to meth labs, there's dangers there from the chemicals.
Absolutely. The chemicals they're volatile, they're toxic. A simple statistic, for every pound of methamphetamine made, you get 5 to 7 pounds of toxic hazardous material that are just wasted. People that are producing in their homes and cooking meth in their homes are not labeling their jars. They may be using baby bottles for part of the chemical reaction or for storage or to discard of the waste. It's kind of amazing what when you hear stories what they found in these homes where they're cooking this
even the
drug.
residual in the home,
the residual
because children
in the home,
put everything
into their mouths. Kids that are raised in meth labs, the statistics are 30 to 75% will test positive for methamphetamine. 10% of kids that are raised in homes of heavy users will test positive for methamphetamine. And addicts or users will try and hide their drug. They hide it in their babies' cribs. We've had it found in baby diaper bags, and these are places that are accessible to children, and they do put things in their mouths and they experiment, and subsequently that's harmful. So I had not too long ago a child that's brought into the office, and Mom says, well, he hasn't slept and he's just screaming and he's unhappy. Well, somehow he had been exposed to methamphetamine in the home.
I mentioned this before, but it has to be disheartening for you as a pediatrician who's just trying to give them the best care possible.
It is, and it's not. We have so many great families, and these kids are wonderful, and they're horribly resilient. And so if you can take them from that situation, remove them from that situation, in best case, educate the parents, help the parents, get them the help that they need, it's very rewarding. It really does make a difference if you can even help one child or one family. And it's happened.
And that really speaks, I think, Dr. Scott, to the value of substance abuse treatment. There's been a number of studies that looked at just cost savings. And this is an area that I think rural Nebraska could really take the lead in. But we know from large population-based studies in both Oregon and California that for every dollar spent on substance abuse treatment, between $5 and $7 are saved in other community services, probably in the kinds of child care situations you're talking about, criminal justice costs, unemployment, vocational rehabilitation costs. And if you add medical costs to that, for every dollar spent on substance abuse treatment, you save $12. So it's a tremendous investment to treat these individuals who have methamphetamine use disorders. The other thing that I think is important to say, and I'm very grateful that we're having this discussion today, is there's sometimes, I think, a demonization of drugs and drug users. And I think Dr. Scott is exactly right. These folks need treatment for an illness, and once these illnesses are treated and people are doing better, they certainly can turn their lives around. And that's what I spend my time doing, is working with persons with drug and alcohol use disorders, and it is tremendously gratifying to see families come together, resume a normal, healthy, happy home life, and that can happen. And really the outcome studies with methamphetamine are very much like outcome studies with other drugs. It's not as if meth, for example, is a worse drug to treat. It looks like the outcome studies are about the same, for example, as they would be with cocaine or other drugs of abuse. So we know a lot about treating these illnesses. The key thing is getting people into the services.
And when you have children and adolescents that are using, it's even more difficult, because there are very few places that will take a 15-year-old or a 14-year-old. They're adult facilities. So trying to find treatment for that adolescent, we know they're using young. We know that we're going to find a 12-year-old that's going to use. Where do you take them for treatment? And some of these kids are very they're bright. I had one young man say, I can go do outpatient treatment, but I'm going to go back home and hang out with my friends in the evening or at night. They're probably going to be the ones that pick me up. How do I get away from it? And it's tricky because you don't have a place to send them, and it's difficult in a situation where there's lower socioeconomic standard. These folks don't have a lot of money, and they may not have insurance, and I think that's an issue in rural communities.
And what about those parents who know that they need to seek help, but are scared to seek help because then my children are going to be taken away from me?
They're going to have their children taken away. And I will say, I have some experience here in Douglas County, and I do think that HHS in Douglas County and Cass County both do a very nice job. I think they try very hard to keep these families together and educate. But again, where do you send them for treatment? And I think, and correct me if I'm wrong, but what I had read a couple years ago is if we can put even moms together with their babies in treatment and have, so we're not having attachment disorders at the same time, it encourages mom to maintain her therapy as well as a positive interaction with the baby. So I think there's a lot of things that we need to do better as a community, and I think treatment's a a big one.
So is this a result too of your study that you're seeing that in these rural areas we need more treatment centers, we need more access to recovery support groups, and where is the solution there? You need more personnel, you need more funding.
Absolutely, and as challenging as it is to treat people even in urban settings or settings that are near urban settings like Plattsmouth would be, it's even more challenging in rural, especially rural remote communities. As an example, one of the, you may know that Nebraska is divided up into 6 mental health regions. And for an example, one of those mental health regions has 18 counties. It's about 22,000 square miles. And there's one comprehensive substance abuse program for a 22,000 mile square area, which is extremely difficult for people to get back and forth. You and I have to spend $3 and something to fill up a tank of gas. If we had to drive 50 miles every day for an outpatient group, if we had a DWI, if we had no money or limited resources to get back and forth, we'd find it almost impossible to comply with that kind of treatment plan. So one of my hopes is that as a result of this study and other studies like this, that more services will be available for rural persons with all drug use disorders, but certainly with methamphetamine use disorders. The kinds of things I'm interested in looking at are things like telemedicine to do substance abuse treatment, also perhaps some what I would call circuit nurse practitioners or physician assistants or therapists who travel a circuit, if you will, and provide both substance abuse and mental health care in small communities. There are many counties in Nebraska, probably about 30 or 40, that don't even have one drug alcohol counselor in the entire county. So this is really an access issue. Distance is a factor. Certainly concerns about privacy are a factor. Resources, driver's license, transportation issues, all of these play into the need for substance abuse treatment. And the key thing about substance abuse treatment is it really is going to require chronic treatment. It isn't just one visit. One visit isn't going to treat methamphetamine use disorders. Typically we're talking about several months of ongoing continuing care, and it's certainly in the face of our data about psychosis, they're also going to need mental health care and perhaps medications for their psychiatric symptoms for some time.
I'm just throwing this out there, would it make a difference for some of these meth addicts, though, to leave their community, knowing that in their community they have those relationships with those people that are also maybe meth users? It's easy access to the methamphetamine that they were using. So even getting the treatment to their area, I understand, is crucial, but there is something to be said about leaving that area and that peer group.
I agree. I think the model that we often use here in Nebraska is that we do tend to place people with drug and alcohol use disorders in a controlled and safe environment, do some intensive day treatment or residential treatment for the first few weeks, but inevitably most of us go home at some point. And so after that first period of weeks or months, maybe in a halfway or three-quarter-way house, they typically do go back to their communities because that's where their families are, their friends. There are times when that can't happen for safety or other reasons. But in any case, no matter where they live, they're going to need ongoing, continuing care. And I think we just have to be, in Nebraska, much more aware of how we're going to provide that. And I don't think right now we know how best to provide that. Again, there's very little research on rural treatment for substance use disorders. Some studies have even been done with telephone-based care. So, for example, if I'm your physician, seeing me a one-on-one, getting to know me a little bit, and then continuing with me as an outpatient afterwards, after we've established a relationship in the treatment maybe of a drug or alcohol use disorder, maybe some of that follow-up care can be done by phone. And frankly, now I do some of that by telephone. I have a patient who lives, or several who live in Lincoln and simply can't get back to see me for their medication. So we do monthly telephone visits interspersed with face-to-face visits. And I suspect some of that is going on in the rural communities as well, just because of the cost of gas and transportation issues. It's just very hard for people to get back and forth.
How do you see the telemedicine working? Would that be kind of a similar scenario?
Well, Nebraska has a skeleton, if you will, of telemedicine already in place. So, for example, University of Nebraska Medical Center may have a site where specialists can provide care, and then they speak with the patient by screen, essentially, perhaps in Kearney or Beatrice. The challenge is that the patient in that area still has to get to the hospital where the camera is, where the communication can take place. But it's certainly better than driving to Omaha or Lincoln to get the care. But again, we don't know very much about whether or not that works well for substance abuse treatment. We don't know at all if it's going to work for methamphetamine. But those are the things we hope to be involved in studying over the next few years.
Have you had any discussions, Dr. Scott, in your group about solutions to the methamphetamine problem?
We've had similar conversations. The access, Plattsmouth is a 25 minute drive from Omaha, but access is inevitably an issue. In our community, we have a large number of people that don't have transportation. We do what we can as a primary care facility, and we try to funnel people into places where we can. But most of the time, we're giving them a phone number and trusting that they're going to leave and make those arrangements. We have had ongoing conversations. But we have yet to come up with a real great resolution for it.
But it's just good to continue to have these discussions, because it really looks like it's going to have to be a community getting together,
and it's going
to tackle this
It
problem.
is. It's almost going to have to be, the state identifying it as a problem. And I agree. I think it's all substance abuse. It's not just methamphetamine that we have troubles getting people treatment for.
And you mentioned, Dr. Grant, too, that even on the national level, and getting some of our senators involved, having discussions with Senator Nelson, you mentioned. So that should help. Even on the national level, at least there might be some funding that could come from that area.
Actually, with Senator Nelson's staff, not with Senator Nelson himself. But I'm just encouraged by the fact that these kinds of discussions are taking place, that we are, this isn't being discussed in isolation. I think the state, clearly all of us have a vested interest in treating our folks who have drug and alcohol use disorders.
Okay, a good place to end. I appreciate both of you being with us, Dr. Kathleen Grant and Dr. Tina Scott. And thank you, everyone, for joining us for this edition of Consider This.
Consider This is an issues and information program produced by UNO Television. More information and program archives can be found at unotv.unomaha.edu. If you'd like to share your comments about this show, call UNO TV at 402-554-2516 during regular business hours.
The 10th season of Consider This is brought to you in part by From the Top, a national program showcasing the musical talents of young people. From the Top can be heard on KVNO Classical 90.7 each Saturday at 6 p.m.